Hello.
Hello.
Okay. Okay. Today's Panigay seminar is Kudalodu Nam அப்படின்றதுதான். நாம்ன்றது வந்து பேக்ல டாக்டர் ராம்குமார் சார். கிரேட் ப்ரைடு இன் திஸ் பிரான்ச். எனக்கு என்ன சொல்லணும்னாக்க, இப்போ நம்ம கிட்ட இருக்கக்கூடிய ஒரு ஸ்டிக்னால ஒரு இது என்னன்னா, இங்க படிச்சுட்டு யூகே போயிட்டு அங்க எம்சிஹெச் எல்லாம் முடிச்சுட்டு திருப்பி ரிட்டர்ன் ஆயிட்டோன்னே யூகே இல்லைன்னா அது எம்சிஹெச் யூகே எம்சிஹெச் இப்போ ஒரு ட்ரெண்ட் வந்துச்சு. மெட்ராஸ்லாம் ஒரு போர்டு பாத்தீங்கன்னா எம்சிஹெச் யூகே இல்ல லண்டன் அப்படிலாம் போடுவாங்க. இது எதுவுமே போட்டிருக்க மாட்டேன். பட் இஸ் சச் அன் ஹானஸ்ட் அண்ட் எத்திக்கல் மேன். எப்பவுமே இந்த விஸ்டம் நாலேஜ் இருக்கிற இடத்துலதான் எத்திக்ஸும் சேர்ந்து இருந்ததுன்னா அது வந்து மேன்கைண்டுக்கு ஒரு பயனா இருக்கும். வெறும் நாலேஜ் இருந்து அதுல எத்திக்ஸ் இல்லைன்னா மேன்கைண்டுக்கு பயனே இல்லை இல்லையா? ஒரு பேசிக்கான விஷயம். ரெண்டும் அன்பு, அறிவு, ஆற்றல், அறத்துடன் செய்யக்கூடிய ஆற்றல் இருக்கிறதுனால தான் நாங்க இவ்வளோ அவரை பாராட்டுறோம். நான் நிறைய கேசஸ் அமைச்சிருக்கேன் அவர்கிட்ட. கேல் பிளாடர் கேசஸ், கொலிசிஸ்டைட்டிஸ் கேசஸ், கொலிலித்தியாசிஸ் நிறைய கேட்கும்போது, சார் வேணாம் சார், நீங்க மருந்து கொடுத்துட்டு லைஃப் ஸ்டைல் மாடிஃபிகேஷன் பண்ணிட்டு இஃப் சர்ஜரி நீடட் நான் பண்ணிக்கலாம் சார். இப்ப வேண்டாம் சார், 6 to 10 months வேண்டாம் சார், பாத்துங்க சார். இந்த மாதிரி சொல்ற சர்ஜன்லாம் பார்க்கவே முடியாது. ஏன்னா இப்ப வந்து நிறைய இல்லை. ஃபீடிங் வருதுன்னா ஜென்ரலா நிறைய வாங்கிட்டு மற்றவங்களுக்கும் கட்ஸ் கொடுத்துட்டு அப்படியே எக்ஸ்பேண்ட் பண்ணலான்னு பார்ப்போம். He just sees the welfare of the patient. He sees the patient as a member in his family. That's why we adore him. Welcome, sir. Ramkumar, sir. Welcome.
Thank you for the introduction, sir. See, this it's a great pleasure for me to join you all. Bala sir has been asking me to do this Panigay for some time. Unfortunately, due to certain personal problems, we could not do it earlier. It's nice to see you all again. Inniki we are going to talk about symptomatology in the lower, originating from the lower GI tract. Okay, Bala sir, start பண்ணலாமா? Shankar sir. Yes. Okay, sir. Shall we go to the first slide, please, sir? Okay. So, what are the common lower GI symptoms? How do the patients present to the primary care with problems of the lower GI tract? They come in commonly with abdominal pain, bloatedness, constipation, vomiting, and other proctological symptoms. The proctological symptoms include diarrhea. Proctological symptoms include tenesmus, rectal bleeding, and some persistent perianal discharge. These are the common things which we see. Today, we'll discuss more in detail about abdominal pain, vomiting, and bloatedness, along with constipation. Diarrhea is it's a vast topic in its own, so we will include that in the next discussion. So next slide, please, sir. Bala sir, next slide. Yeah. So first of all, we should understand where are the what are the diseases that can cause these symptoms. So the common diseases are enteritis or gastroenteritis, acute appendicitis, diverticulitis, hemorrhoids, fissure, fistula, irritable bowel syndrome, ischemic colitis, and mesenteric lymphadenitis, and also cancer of the colon and rectum. So based on this, we will discuss about the symptoms and find out how to evaluate and treat it. The next slide, sir. The commonest presentation to a primary a surgical presentation would be of abdominal pain. So abdominal pain is evaluated predominantly by a good history and a carefully directed abdominal examination. So to identify the causes of abdominal pain, we need to know the site. So abdomen is divided into 10 quadrants. So the right upper quadrant, the epigastrium, the left upper quadrant, bilateral flanks, periumbilical region, bilateral iliac fossa, the suprapubic region, and also the 10th quadrant is the scrotum. So pain in the right upper quadrant, we should always think about gallstones, gastric or duodenal ulcers, pancreatitis, and lower lobe pneumonia. In epigastric pains, we have to think about ulcer, again ulcer disease, heartburn, pancreatitis, again gallstones causing bile duct stones can cause epigastric pain. And abdominal wall hernias in the epigastrium can also cause epigastric pain. The other most important thing which presents as epigastric pain is an inferior wall MI. So in a patient who has susceptibility towards ischemic heart disease, we should never forget inferior wall myocardial infarction as a cause for acute epigastric pain. Left upper quadrant, again, it can be caused due to gastritis, ulcer disease, pancreatitis, splenic infarcts, splenic abscesses. Okay. And the flank pains can be due to kidney stones, which is the most common cause of abdominal pain in our part of the world. Upper urinary infections, constipation, and also hernias, lumbar hernias. Central abdominal pains can be due to pancreatitis, acute appendicitis, especially in the early part. Early acute appendicitis presents as a periumbilical pain, which later on moves to the right iliac fossa. Ulcer disease again can cause central or periumbilical pain. Small bowel pathologies like inflammatory bowel disease, colitis, small bowel problems, other small bowel problems like adhesions, intestinal obstruction, internal hernias, umbilical hernias, especially all these can cause central and periumbilical abdominal pains. The left flank pains, we should think about along with kidney stones. The pain can be due to diverticulitis, constipation, and inflammatory bowel disease. The right iliac fossa pains, the first thing that should come to your mind in a young adult would be acute appendicitis. In any women of childbearing age, an ectopic pregnancy or an ovarian pathology should also come to the differential diagnosis. Okay. Suprapubic pains can be due to urinary infections, could be due to diverticulitis, inflammatory bowel disease, or pelvic pain in women. Pelvic pain, which includes ovarian torsion, pelvic inflammatory disease, etc. The groin pains are predominantly due to hernia or epidermolysis. And to identify and to diagnose it, it is always important to examine the 10th quadrant, which is the scrotum. Next slide, please, sir. So, abdominal pain. So, when we talk about abdominal pains, there are three classes of abdominal pains. One is the visceral pain, the somatic pain, and the referred pain. Okay, visceral pain is the pain originating from the internal viscera, which includes both solid and hollow viscous. Somatic pain originates from the abdominal wall and the ribs and everything. And the referred pains are due to the pains originating from the viscera due to a developmental, and the pain which is referred to a different region due to developmental, basically, say for example, if you have a diaphragmatic pathology, you can have pain in the right shoulder, which is because the diaphragm, when it develops from the cervical, from the C5 area. So the tip of the shoulder also has a same innervation as the diaphragm, and therefore diaphragmatic pains can be referred to the shoulder. So next slide, please, sir. So now coming to the visceral pain, it originates, as I said, it originates either from the solid organs or the hollow organs, and it becomes localized. It is actually a. It is not. The visceral pain originates from the hollow organs or the solid organs. Okay, and these organs are supplied by the autonomic nerves, and because there is no peripheral nervous system involvement, it is only a vague pain which is felt as a diffuse pain rather than a very localized pain. Okay, when the visceral peritoneum is involved and irritates the parietal peritoneum, then this pain gets localized. Okay, so the causes for this pain could be due to inflammation, which is, for example, acute appendicitis. It's an inflammation of the appendix, and as long as it is, as long as the inflammation is there only localized to the appendix and not the parietal peritoneum, the pain is actually felt in the periumbilical region due to the pain which is sensed through the autonomic nervous system, and the appendix belonging to the midgut. The pain actually is shown in the midgut region, which is the periumbilical region. When it's distended, the other reason for for the visceral pain is distension. Say, for example, if there is a intestinal obstruction, it is small bowel obstruction, where the small intestine distends due to the increase in contents which are not being able to be excreted. You have a pain which is related to the distension, and this is usually felt if it is in the midgut around the umbilicus as a crampy pain. If the colon is obstructed or distended, then the pain is either in the suprapubic region or in the bilateral flanks, which is due to the lower gut, which is basically L2, L3 levels. Okay, and the last cause for the visceral pain is ischemia related. This ischemia related pain, we can give an example as if there is a blockage of the superior mesenteric artery or one of its branches, the blood supply to the intestine gets, and this is called as mesenteric ischemia, and it is a very life-threatening condition wherein the patient develops severe pain which is diffuse and is not associated with any signs of peritonitis or any other signs of abdominal disease. So only way you diagnose is with a low threshold of suspicion, wherein we have to go in early and identify it with the arterial blood gas analysis. Okay. All viscera transmit pain signals from visceral afferent neural systems through the autonomic nervous system, and therefore the pain is not localized to one specific area. So it is actually, say, the foregut pain is felt in the epigastrium, the midgut pain is felt in the umbilical region, and the hindgut region pain is felt in the suprapubic or in the flank regions. Okay. The body responds through the body responds to this pain through parasympathetic stimulation causing nausea and vomiting, sweating, bradycardia. Okay. The somatic pain. Somatic pain is a sharp pain that travels along the specified dermatomes to the spinal cord. So, a pain in the say for example, if there is a perforation where the parietal peritoneum is involved, the pain is localized to that area. So, in upper GI perforation, the pain is usually, the tenderness is, pain and tenderness is predominantly in the upper abdomen. Whereas in a lower GI perforation or like acute appendicitis or diverticulitis, the pain is either felt in the right or left iliac fossa accordingly. Okay. The other cause for sharp pains, somatic pain is abdominal wall lesions like abdominal wall hematoma, which can be caused due to a severe bout of coughing, causing rupture of the inferior epigastric artery, causing a hematoma, or due to tumors involving the abdominal walls. So the other type of pain which I told you about is the referred pain. It actually originates not in the same place where the pain is felt. Okay, it is due to neural pathways, usually which is due to developmental issues. So, for example, as I told you earlier, inflammation of diaphragm causes pain in the neck or shoulder because the diaphragm initially during development, during embryological development, develops close to the shoulder and has got the same nerve supply, which is the C5 dermatome nerve supply. So, after cholecystectomy, one of the causes for patients getting readmitted is due to shoulder pain. If we don't empty the CO2 pneumoperitoneum properly, or if there is any collection of fluid or bile close to the diaphragm, it causes severe pain and irritation. So we should actually educate the patients of shoulder pain and its background to prevent readmissions or to early detect complications early. Okay. The dissecting abdominal aneurysm, basically in an abdominal aneurysm which causes dissection, the pain is actually referred between the shoulder, which is basically people come as pain in the back. This is again due to a development where the embryonic aorta develops posteriorly in between the shoulder blades. Okay. And we should always think about whenever a patient comes with back pain, the first two first intra-abdominal causes, which should be thought about is pancreatitis and ruptured aneurysm, if they have the adequate risk factors. Next slide, please, sir. So, as I told you earlier, most of these causes for the abdominal pains can be diagnosed with the adequate history. So, what are the things that you should ask? Where is your pain? So, as I told you earlier on, the initial division of the abdominal wall into quadrants, abdomen into quadrants, it will always help you in giving you a short method to actually direct your questions. You cannot ask all the questions to everybody, otherwise your OP will never end. So use that as a blueprint to ask the questions. The next question is to ask is to where does the pain radiate anywhere? Okay, referred pain is different from pain radiating. Okay, so referred pain is I hope that you understand the difference between referred pain and radiating pain. Radiating pain is a pain which is there, and from say, for example, if you have a renal colic, you have a pain which radiates from the groin, from the loin to the groin. Okay, And if there is a pain with pancreatitis, you have an epigastric pain radiating to the back, whereas a referred pain is due to, say, for example, as I told you earlier on, the pain in the diaphragm gets referred to the shoulder. And you understand the difference? Anybody who doesn't understand the difference, please ask me now. Okay, so no responses, so I'll go ahead. So you should ask how the pain began, whether it is a sudden onset pain or a gradual onset pain. The sudden onset pain usually indicates to something acute, and something like a stone-related pain or a perforation-related pain just starts suddenly at a snap of a finger. And chronic pains like diverticulosis related pain or a cramp related pains usually of a slow onset. And is there anything that is whether the pain is associated with eating? Gallstone related pains usually are postprandial. Okay, and whether is it related to any defecation? Is it associated with vomiting? Does any associated factors like how the bowels are? Does anything that makes the pain better or worse? Or you should also ask whether you had the similar pains before also. Next slide, please, sir. So whenever you ask about the pain, you should also ask about associated symptoms. If you are suspecting a GI problem, you should ask for gastrointestinal symptoms like vomiting, nausea, whether it is related to food, whether it is before food or after food. Epigastric pains, which are before food, which are relieved by eating, is usually due to a duodenal ulcer. And therefore, patients with chronic duodenal ulcers tend to eat to relieve the pain and therefore are obese. Whereas a patient with gastric ulcer, the pain is aggravated by eating. Okay, so that is because the food goes directly into the stomach and irritates that ulcer, especially the acidic ones, causing a pain. And therefore, people with gastric ulcers tend to undereat and therefore are nutritionally challenged. They are very thin and they have their pain, which is usually aggravated by eating. Okay. Biliary colics also are related to eating, especially fatty food. The reason why they have pain, which is stimulated by fatty food, is because the fat in the food stimulates the hormone called cholecystokinin, and this stimulates the gallbladder, causing contraction of the gallbladder. And during the contraction of the gallbladder, the stones, unfortunately, if they get stuck in the neck of the gallbladder, causes a colicky pain, which is either in the epigastrium or in the right upper quadrant. Okay. So you also have to ask about whether the pain is relieved by passing motion. The pains due to diverticulosis or adhesions are typically relieved after a bowel motion. Again, irritable bowel syndrome related pains also can be relieved or aggravated either by a bowel motion. Okay, so differentiate, it is very important to have a accurate history. You should also ask about the genitourinary symptoms, which includes burning and burning micturition, any strangury, or whether there is any blood in the urine. This would point out to a stone disease, urinary tract infections, or a pyelonephritis. Never forget a gynecological cause in any women. So a tauted ovarian cyst can happen either in the younger or older age groups, and that is typically a pain which is either one of the iliac fossa radiating to the thigh and in the to the external genitalia. And any women of a childbearing age group, irrespective of periods, we always think about ruptured ectopic as a cause. So whenever a young woman of childbearing age group comes, and even if you are you have a diagnosis of appendicitis, anything on ultrasound, please do not forget to ask for a urinary pregnancy test prior to going ahead with surgery for the given or the ultrasound diagnosis. This happened to me very recently when one of our radiologists brought his wife with acute appendicitis. Okay, so in spite of the fact that he was a radiologist, he did the scans. I asked his wife, and she, in spite of the fact that she's also a dermatologist and had a that her periods were recently completed, I stood my ground and asked for a urinary pregnancy test, and that revealed that the beta HCG was positive, and therefore I was prepared that it possibly could be an ectopic. And I had already called the gynecologist and then started the laparoscopy. And when I went in, it was a ruptured ectopic, found a lot of blood, then handed over the case to the gynecologist, and then did a tubectomy and came out. Salpingectomy, I'm sorry, not a tubectomy, a salpingectomy, and came out. And she was well. So it is the doubt, it's very important that you have to keep that in your back of your mind prior to going ahead with any procedure. So the other thing which you also have to think about is cardiac and pulmonary causes. Say, for example, you are called to evaluate abdomen for an elderly person who is actually bedbound. Always think about if the pain is in the epigastrium or in the right or left upper quadrants. Always think about the cardiopulmonary cause. Pulmonary causes include basal atelectasis, an empyema, a pleural effusion. All these things can cause and present with an epigastric pain, epigastric or upper abdominal pains. The other thing which should never miss out, especially in patients with epigastric pain, is, as I told you earlier, it is we have to always think about inferior wall myocardial infarction. If you miss that and not do a cardiac evaluation and think in terms of a gastrointestinal problem and do an endoscopy, you are very certain to lose the patient on the endoscopy table. So we should always, if there is a patient who has a potential cardiac problem, who's got a potential for cardiac problems, we should always think about a myocardial infarction, do an ECG prior to evaluation of the gastrointestinal symptoms. Okay, so we should always, there are other multiple medical causes for abdominal pains also. I've seen patients with diabetic ketoacidosis who present purely with abdominal pain and no other symptoms of diabetes. Okay. Evaluation shows ketones positive in the urine, and I have seen people who think that or attribute the ketosis due to the vomiting caused due to gastritis. However, it is the diabetic ketoacidosis which actually causes both abdominal pains and the vomiting. alcohol-related ketoacidosis, uremia. Uremia can very commonly present with central abdominal pains. Sickle-cell anemia. Sickle-cell anemia. We don't see that much of sickle cell disease here. However, in the West, where I was, people from Africa have a lot of. We do see a lot of patients with sickle cell disease there. Again, porphyria. It's a very under-diagnosed cause for abdominal pain. We tend to miss out. Usually, it's a diagnosis where all other causes, patients might have had several CTs, several endoscopies, and then when they were medically evaluated, we find porphyria. SLE with vasculitis can cause central abdominal pains. Hyperthyroidisms can usually cause abdominal pains due to hurried gut, where patients with hyperthyroidism always have loose motion, and that crampiness can cause pains in the abdomen. The other causes, if there is a history of one in previous times where there was no task marks, people used to have used to go and made illicit liquor and make illicit liquor and have it, and come with methanol poisoning, usually stated with blindness and eye-related problems, along with abdominal pains. The mortality is quite high with patients with methanol toxicity. Lead toxicity. Again, I have not seen much of patients with lead toxicity. However, in the primary health centers where we worked before, we used to see people who come with lead toxicity. That is mainly because of having EM post what do you call it? Vessels. They have food from vessels made of or lined with lead and can cause lead toxicity. Usually comes with abdominal pains and liver-related problems. Scorpion bites, again, it's a very rare cause for abdominal pains. I have not seen personally in one patient with scorpion bite related this thing, but scorpion bites are also well known to cause pancreatitis. We commonly we forget the common cause of pancreatitis until that causes pancreatitis in the exams, and usually we get scolded by our examiners because of that. Okay. As I told you earlier, AMI, pneumonia, all these can cause abdominal pains. Again, you should always think about testicular torsion, especially in a patient coming with suprapubic pains. You should always think about the testicular torsion, and also one of the reasons why you should examine the scrotum as well. Testicular torsions and hernia can also cause abdominal pain. So an abdominal examination is never complete unless scrotal examination is also completed along with that. So we have to think about the infectious causes. Streptococcus pharyngitis, Rocky Mountain spotted fever. I've seen one by patients. Infectious mononucleosis. We do see that, especially associated with lymphadenopathy, and it gets exacerbated if we use penicillins, especially amoxicillin. Okay, so abdominal wall causes also have to be thought about. Muscle spasms, hernias, abdominal wall hernias, herpes zoster can also should also be thought about. Herpes zoster, how is the pain? Usually unilateral pain, which is localized to one or two dermatomes, which are usually contiguous, and it is specifically is on only one side of the abdominal wall. When the herpes zoster is bilateral, we should always think about immunocompromised situations like human HIV, diabetes, or other immunocompromised situations. Okay. Next slide, please, sir. Okay, so again, because there are several causes for the abdominal pain, our physical examination should also be well directed towards what our clinical suspicion is based on the history. So we should first do general examination starts from the head to foot. Look for anemia. Anemia could be due to a blood loss, chronic blood loss from a duodenal or a gastric ulcer or a malignancy, intra-abdominal malignancy. You should look for jaundice. Jaundice could be caused due to either gallstone disease or any pancreatic or pancreatic or metastatic problems from colonic cancers. Look for signs of liver failure. Always look at the pulse rate, blood pressure, any signs of cervical lymphadenopathy. Cervical lymphadenopathy can be due to a metastasis from intra-abdominal malignancy. And then after you finish off the general examination, you come to a local examination, which includes inspection. Look for any you first inspect for any obvious masses, whether there is any fullness, whether there is any ascites. Then you look for any restriction of movement with respiration, and then do a palpation. So after your inspection, you palpate. When you palpate, you first examine the normal abdomen, normal abdomen first, and then you finally come to the place of the abdominal pain, and be very gentle. You should also percuss and auscultate. The findings from percussion and auscultation are also very important. If we want to say, example, for percussion, in a patient with abdominal pain, a percussion tenderness can be used rather than a rebound tenderness, which is much more human, and it can cause less discomfort to a patient. So if a mild percussion causes pain in the right iliac fossa, then we should think about a suspicion of acute appendicitis. Okay, right iliac fossa pain which is not associated with tenderness on percussion or palpation is usually unlikely to be appendicitis and more likely to be related to stones or a urinary tract infection or anything which is not causing any peritonism. Okay. Auscultation. In a patient with abdominal pain, severe abdominal pain, with a very silent bowel sounds, with absent bowel sounds, it's likely that some amount of peritonism is there. Peritonism basically is inflammation of the peritoneum, and it is the inflammation of the peritoneum basically causes reduction of bowel sounds due to the bowels going in for ileus. Okay. Next slide, please, sir. So to continue with the physical examination, if we are suspecting, as I said, genital examination and scrotal examination should always be completed to rule out any hernias, any testicular torsions as a cause of abdominal pain. In females, it is always important to rule out to do a pelvic examination or vaginal examination to check for any Tarted ovarian cyst, pelvic inflammatory disease, and everything. Rectal examination is mandatory for everybody, especially in the presence of lower abdominal pain, to rule out um, any causes in low pelvic causes for abdominal pain. In addition, the examination should always be completed by a thorough head-to-toe examination. Next slide, please, sir. So what are the differential diagnoses? As I said to you earlier on, we'll just go through one by one as to how the abdominal pain would be in these conditions. Okay, I will just highlight only the ones which are in the hindgut. Appendicitis. So how will the pain be in appendicitis? The patient presents to you, usually it's a young adult. Doesn't mean that it cannot present in an elderly person. Usually it's a young adult who presents with a dull achy pain, starts in the central abdomen. Usually there are no aggravating or relieving factors. After some time, this pain usually goes off, and then after a few hours, it localizes to the right iliac fossa. And the pain, if you ask history, if the patient will tell you that the pain will be worse on movement, and therefore they prefer to lie down. It will be also associated with nausea or vomiting. They might have a little bit of ileus, and therefore the patient might not have had a bowel motion. But it is not mandatory that they should tell that. It is associated with the lack of appetite. Acute appendicitis is also associated with fever. So a pain which radiates from the central abdomen or around the umbilicus to the right iliac fossa, associated with nausea, vomiting, lack of appetite, plus or minus fever. Always think in terms of acute appendicitis. Okay. The second cause is biliary colic. This is an upper GI cause, but still I will go through it. Usually it is a pain which comes in the epigastrium, usually after eating a fatty food, lasting for a few hours, and then either spontaneously resolving or resolving with antispasmodic medications. How will you differentiate that with the cholecystitis? The cholecystitis pain does not spontaneously regress. Usually the pain is constant, it is worse, it is associated with the worsening of movement, whereas the pain in biliary colic, which is the right upper quadrant of epigastric pain, which is actually not be worsened on movement or breathing. Whereas cholecystitis pain, because of inflammation of the parietal peritoneum, is localized to the right upper quadrant and it is worse on movement. Cholangitis. The pain. What is cholangitis? Cholangitis is an infection of the biliary tract. Basically, it happens due to bile duct calculi or obstruction of the biliary tract, and the obstructed biliary tract is a very good nidus for anaerobic and gram-negative bacteria, which starts proliferating within the biliary tract, causing fever, jaundice, and pain. So, what is that? Is there anything that strikes you in mind? Fever, jaundice, and pain is Charcot's triad. Okay. Charcot's triad is fever with rigors, epigastric or right upper quadrant pains, and jaundice. This is a typical triad which occurs in an obstructed biliary tract, either due to stones or due to malignancy, or commonly due to stones. Okay, bowel obstruction. Bowel obstruction. The obstruction can be due to several reasons. It would be due to commonest cause of bowel obstruction in a patient with no previous abdominal surgery is abdominal wall or internal hernia. Okay, so the commonest cause of bowel obstruction in a patient with no previous abdominal surgery is abdominal wall or internal hernia. Understand? So the commonest cause of bowel obstruction in the patient who's had previous abdominal surgery is adhesions. Okay, so how do these present? When the patients with bowel obstruction, usually it is a crampy and intermittent. Usually, central pain is usually a central abdominal pain associated with vomiting, which is bilious. Bilious. Why is it bilious? Bilious because the level of obstruction is below the second part of duodenum. The bile which gets produced in the second part of duodenum gets there is a stasis of this bile which gets regurgitated into the stomach, and then it is then the patient vomits the bile as a due to the obstruction of the flow. Okay, so it is a bilious obstruction. It's a bilious vomiting associated with intermittent crampy central abdominal pain is how a patient with bowel obstruction presents. So then next thing is on the list is diverticulitis. So how do patients with diverticulitis present? Diverticulitis, where are the diverticula commonly present? Commonly present in the sigmoid colon. The second common site is throughout the colon, and the third common site is in the small intestine. And fourth, it can also present in the duodenum. So diverticulitis, when we blindly tell diverticulitis, it usually indicates diverticulitis of the sigmoid colon, because it is the commonest site where diverticulae present. Diverticulitis is inflammation of these diverticula or outpouchings. So they usually present as pain in the left flank or iliac fossa. And if it is diverticulosis without, that is, which means that it means without the presence of infection, it usually presents as a dull, achy pain. However, in the presence of diverticulitis, which is inflammation of the diverticula, it as the parietal peritoneum is also inflamed, you can have a localized left iliac fossa related pain, which is localized to the left iliac fossa and worse on movement. Okay, and this pain is usually relieved at least partially after defecation or passing flatus. Okay, how do a patient presents with ectopic pregnancy? The ectopic pregnancy usually presents as a diffuse abdominal pain, but the pain is predominantly in the lower abdomen. But once the ectopic ruptures, the lower abdominal pain becomes diffuse. The reason being, the ruptured ectopic will cause a lot of bleeding into the peritoneal cavity, and blood being an irritant causes peritonism, which is irritation of the peritoneum, parietal peritoneum, causing severe pain throughout the abdomen. In addition to this, the patient will have this pain is usually worse on movement, and the patient lies still and and even if the patient tries to get up, due to a huge loss of blood, they get postural hypotension and have fainting attacks. We've seen patients presenting with ectopic pregnancy with a hemoglobin of 3. So it is very important to identify that and intervene appropriately with an appropriate specialist. Gastroenteritis. How does the pain of gastroenteritis be? Usually it is associated with diarrhea or vomiting, and the pain, crampy pain, and either central abdomen or in the lower abdomen, and is usually relieved after a passing motion, and may be associated with fever. Okay, what is intussusception? Intussusception is a problem where the intestine, either the small or the large intestine, goes into the lumen of the adjacent intestine. Basically, சிறுங்குடல் பெருங்குடல் சாப்பிடுதுன்னு சொல்லுவாங்க, தமிழ்ல கேள்விப்பட்டிருப்பீங்க. That's literally what intussusception means. So This is the small intestine, and this is a portion of the intestine, and then the proximal portion goes into the distal intestine, causing narrowing of the of that portion of the intestine, causing obstruction. Usually, this presents initially without obstruction presents as a dull, achy pain, and when obstruction sets in, it usually is a pain due to the obstruction and ischemia, which is a intermittent crampy pain associated with vomiting, which is bilious. Okay, interception can be due. It usually is either in a very young age group, in children less than 5, or in the elderly people. In people, it very rarely happens in adults. Usually, it is either in the children age group or in the very elderly age group. In children, it is due to the thickening of the mucosal lymphatics due to a viral infection, which acts as a focus where this lumen goes into the other lumen. So basically, when there is an intramucosal lymphatics which gets enlarged, it acts like a polyp, and this polyp, the intestine thinks that it is a particulate of a particular food, and then it starts pulling itself into the distal intestine. Okay, so similarly, in elderly people where they have a luminal polyp or a growth, that can act as a nidus for an interception. Okay, so mesenteric ischemia. This is one very important cause of abdominal pain, which you should never forget, especially if you are dealing with elderly people. So mesenteric ischemia is how do they present? They usually present with diffuse abdominal pain with no signs of any serious abdominal pathology. So when you examine the patient will be will have a non-distended abdomen, which is completely soft, no tenderness. However, the patient will be complaining of a very severe pain, which is not relieved by routine medications. So you should never think that these patients are feigning or even acting with abdominal pain without any pathology. You should always think about mesenteric ischemia. So in any patient with severe abdominal pains with no supporting signs of abdominal disease, always suspect intestinal ischemia. So how do you confirm intestinal ischemia? The first thing you have to do is an arterial blood gas analysis. Arterial blood gas analysis is a sample of blood which you take from the artery, usually from the radial or the femoral artery, and send it for a gas analysis. And if this shows acidosis, which is shown by increase in lactates, and also in addition, you also have the base excess, which is increased. So if there is a acidosis where the pH is less, associated with increased lactates, and plus or minus increased base excess, you always have to think in terms of mesenteric ischemia and confirm it doing an urgent CT scan of the abdomen with contrast, intravenous contrast, and to see whether the bowel wall. First, when you do a CT, you have to look at 3 things. One, is there any blood flow into the mesenteric arteries? If there is a blood flow to the mesenteric arteries, are the bowel walls enhancing properly during the arterial and venous, portal venous phase? And third, even if these 2 are there, whether there is any mucosal or bowel wall thickening. So these are the 3 things we have to look at when you do a CT for a mesenteric ischemia. Okay, and this should never be forgotten, because if you fail to identify it during the first couple of hours, there is a very high risk of mortality for the patient. Okay, so ovarian torsion. So I told you about ectopic pregnancy. Ovarian torsion also can happen in women irrespective of their childbearing status. It present in young children, adolescents, women of childbearing age group, and also in elderly women who have either benign or malignant ovarian cysts, which can twist on an axis, cutting off the blood supply, and therefore will act as a ischemia to the ovaries and cause severe pain, which is which can be related to a pain which is caused due to a torsion of the testis. So it is quite a severe pain, usually in the lower abdomen, radiates to the external genitalia and to the thigh. Okay. Pancreatitis. How does a patient with pancreatitis have pain? Usually it's an epigastric pain, and it radiates to the back. So when a patient comes with an epigastric pain, if the patient is leaning forward and holding their abdomen and their back and leaning forward, it usually indicates pancreatitis. So this is how, if the pain doesn't radiate to the back, you have to think in terms of either a gastritis or a biliary colic or other causes. Okay, so typically a pancreatitis pain radiates to the back and gets relieved on leaning forward. Patients with chronic pancreatitis, there are people who have said to me that they have not been able to lie down flat at all, and as leaning forwards is the only thing which gives them a little bit of relief. They always, even at nights, just sit up and lean forward and sleep. Okay. Inflammatory disease. Again, this can cause lower abdominal pains, similar to either a UTI or a ovarian cyst related or a tarted ovarian cyst related pain. But this pain is usually a more chronic pain, and it is associated with a vaginal discharge and plus or minus fever. Okay. Perforated peptic ulcer. So again, it is an epigastric pain which is sudden in onset, and it is worse on movement and associated either with vomiting or hematemesis. And basically, they come in with peritonism, pretty sick, with hypotension and tachycardia, with or without fever. Okay. The perforated peptic ulcer, luckily we have with the advent of the ranitidine and now the proton pump inhibitors, it is very rare, but still in patients who are alcoholic or who actually ignore their health, we do come across patients with a perforated peptic ulcer. Usually the pain is in the epigastrium and sudden in onset, constant. It sometimes during the transit between the acute phase and peritonitis phase, between the chemical peritonitis phase and the bacterial peritonitis phase, you have a little bit of improvement. And during this time, if the doctor sees the patient, there is a likelihood that a diagnosis can be missed. Okay. Ruptured or a leaking intra-abdominal aneurysm can also present with abdominal pain. In fact, when I came back from the UK, we had one patient who presented with epigastric pain, who I admitted him on Saturday night, and he came with a very severe pain. The patient was about 45, 50 years age, severe pains. Initially, I thought it was gastritis when I saw him in the casualty. Then, because the pain didn't subside in spite of proton pump inhibitors and also analgesics, we then thought it could be pancreatitis. So, lipase normal. Maybe the amylase was slightly elevated. So, we were thinking in terms of a pancreatitis or a gastric or a duodenal ulcer. However, because it was a Sunday, I didn't actually go for an endoscopy and asked for a CT. And luckily for both the patient and me, it was a leaking intra-abdominal an aneurysm, which is basically not a leaking, it was a dissecting aneurysm. And he was managed with an endoluminal stent, and then discharged home by the vascular surgeons. And he never forgets to wish me during every Deepavali time. So I'm happy that I didn't do an endoscopy and potentially kill him. So we should always think in terms of leaking intra-abdominal aneurysm. Usually presents as a diffuse abdominal pain, which radiates to the back. And this is usually associated with a very soft abdomen and no other signs. The only way you can diagnose it is with high clinical degree of suspicion and either an ultrasound or a proper CT scan. Testicular torsion. In our part of the world, people, in spite of the fact that the pain might have originated in the testis, they always tell us about lower abdominal pain rather than testicular pain. So unless you probe in and ask ask about about whether the pain is there in the testis, they would not tell you. And therefore, any lower abdominal pain, always examine the testis. Always examine the lower the scrotal compartment also. And testicular torsion and epididymoarthritis should always be ruled out for any patient with inguinal or a lower abdominal pain. Urinary colic, I'm sure Dr. Guru Balaji would have gone through about the symptomatology of it. Usually, it's a loin to groin pain. If it's an upper abdomen, it's an upper ureters. It usually pain starts in the loin or in the flank, and as it goes down, the pain moves from the loin into the groin. And if it is the pain is there in the penis, if it's there in the urethra, if the stone is there in the urethra, stuck in the urethra, you can have pain which radiates to the tip of the penis. Okay. Volvulus, again, volvulus is a twisting of the intestine. It can happen either in the small intestine or more commonly the sigmoid colon or in the cecum. So volvulus, it is where the intestine gets knotted or twisted, and usually the pain is typical of a bowel obstruction related pain. Okay. Any questions, sir? Or shall we keep the questions to the last? Okay, sir. Next slide, please, sir. Okay, so how do you evaluate a patient with abdominal pain? As I said, once you take a good history and then do a thorough examination, we will focus our lab testing also. So lab testing should be based on the clinical suspicion. So if you are suspecting a urinary colic, you should direct your investigations towards urinary colic to identify the stones. The primary would be in the form of a complete blood count, an ultrasound abdomen, a urine analysis, and that way, and the urea creatinine in that way. However, from the GI point of view, if you are suspecting gastrointestinal cause, you should think we should do a complete blood count. Why is the complete blood count important? You might actually see anemia, which can be due to either a ulcer. It can be anemia due to an ectopic pregnancy. It could be, you can see a raised white cell count due to something like acute appendicitis, cholangitis, pancreatitis. You can have a low blood count due to low hemoglobin due to a leaking aneurysm. You can have a low hemoglobin due to intra-abdominal malignancies. So complete blood count is very important. Again, a urine analysis and a urinary pregnancy test are important. As I told you earlier, urine analysis is if there is a blood in the urine, you should always think in terms of urological cause for the abdominal pain. Any proteins in the protein or any evidence of pus cells in the abdomen should in the urine analysis should point yourselves towards an UTI. Amylase and lipase, it is important because it can be elevated in pancreatitis. It can also be elevated in a perforated ulcer. So an elevated amylase or lipase should not rule out a perforated ulcer. Okay. And you should, as I said to you earlier, epigastric pain, the patient with the higher risk for ischemic heart disease, always do an electrocardiogram. Never forget to do an electrocardiogram. Okay. Next slide, please, sir. So again, what are the radiological studies that you should think of? So if you're suspecting a perforation, you should think in terms of a plain X-ray of the chest. Is it a plain X-ray of chest or abdomen? We should do a plain X-ray of the chest. And the view you should ask for is a plain X-ray of the chest, PA view in an erect posture. The reason why we want an erect view is to look for any air under the diaphragm. A supine abdominal X-ray, a supine chest X-ray, or an abdominal X-ray might easily miss it because air can actually will actually take the most undependent part, which is basically the topmost part. Air basically comes up, isn't it? So if there is a perforation, and if the patient is in the erect posture, if they take an X-ray in the erect posture, you will see an air under the diaphragm. Normally, you see the dome. If you see the gastric air bubble, and beyond that, there will not be any extraluminal air. If you find extraluminal air, it is indicative of a visceral perforation. Most commonly, an upper GI visceral perforation. We do also see air under the diaphragm in patients who have had colonic perforation also. Okay, so that is why an X-ray chest is very important. The other thing which also you can see is a dilated stomach in a patient with either a gastric volvulus or gastric distension due to gastric outlet obstruction or gastric ileus. You can actually see a hugely distended stomach in the X-ray of plain X-ray of the chest. An abdominal X-ray will give you details about an obstruction or an ileus. I will tell you how to differentiate about an obstruction or ileus when we discuss about constipation. Okay. What is the role of ultrasound? Ultrasound ultrasound is a very operator-dependent investigation. We do have excellent people. We've got people who are very excellent in reporting ultrasounds. So, what are the places in which you ask for an ultrasound? In a patient with perforation, do you ask for an ultrasound? No, there is no need. If you are suspecting a perforation, a CT would be a better investigation. To identify it. Okay. So what are the roles? Where do you ask for an ultrasound? So when you're suspecting, when you come to when you sort of ran through the differential diagnosis, what are the places where you actually ask for an ultrasound? Biliary colic, yes, you ask for in a biliary colic or cholecystitis. Ultrasound is the investigation of choice. Whatever else. In an ectopic, again, you can actually see a lot of fluid in the abdomen, and if you're lucky, you can actually see the ectopic pregnancy also in the tubes. Okay, what else we can see stones, renal calculi, and see uretary calculi. What else is an ultrasound used for in a patient who presents with acute abdominal pain? Is it useful for identifying a patient with intestinal obstruction? No. Why? Ultrasound is air is a very poor conductor of sound waves, And therefore, in a patient with obstruction, will have a lot of gaseous distension, which will actually prevent proper visualization with an ultrasound. And therefore, an ultrasound is useless to diagnose anybody with obstruction. So it is useful for stone disease, either in the biliary stone disease or ureteric stone disease, or it is useful to identify any solid organ problems like a liver abscess or a splenic abscess. Splenic infarcts are not diagnosed by an ultrasound unless they are you have a very excellent sonologist who can actually identify the change in echo texture, which is wedge shape. Usually, it is not a diagnosis made on ultrasound. So, pelvic diseases, acute appendicitis, all these things can be diagnosed with with an ultrasound, whereas a normal ultrasound should not rule out anything. We should not be fooled by presence of a normal ultrasound. So if you are suspicious, you have to go ahead after the ultrasound. Go ahead with a CT, either with or without contrast. Okay. Next slide, please, sir. So I told you about the chest X-ray. You can see. I don't know whether you can see my pointer. The below the right hemidiaphragm, you can see an arch of a gas, which is basically the gas which is present between the dome of diaphragm and the right, so between the dome of the liver and the dome of the diaphragm. Sir, you can see it? Yeah. So this is where. So you can point it out, sir. So this is where the air in the diaphragm is. So normally this is the one on the other side. The right hand side is the one on the right hand side is the gastric air bubble, which is the air which is inside the gastric lumen, whereas the one in the right hand side is basically abdominal gas, which is seen between the diaphragm and the liver. Yes, sir. Okay, so the next is an ultrasound picture. Ultrasound picture. Basically, you can see this tubular structure. Unfortunately, not everybody, not in everybody, we can actually see this very clearly. Okay, so appendicitis is you can only pick up about 40 to 50% of acute appendicitis with just an ultrasound alone. So in the West, where we are rarely allowed to do an ultrasound, a CT scan for acute appendicitis, there is there's a rate of about 15 to 20% rate of either a normal appendix being taken out on laparoscopy, or there are instances, in worst cases, instances of missing an acute appendicitis and treating them conservatively. Okay, the next slide, please. So Indians being innovative, we actually combine investigations. We ask for an ultrasound, and then if there's a suspicion, we ask them to do a CT screening of the abdomen, and this helps us to identify with accuracy about 99% patients with acute appendicitis. You can see here the pelvis. This is a case of pelvic appendicitis. This patient's present with pelvic pain, actually, not as a typical right iliac fossa pain. This appendix is actually if you see that it is in the pouch of Douglas, basically between the rectum and the uterus. And there's a lot of, sorry, sir. Which one, sir? I couldn't hear you, sir. Oh, this one, sir. Annotate. Where is the annotate? I cannot see it, but I can. Can you see me, sir? Can you see my pointer? So come to the first picture. Here, this one, sir. How do I show the pointer, sir? So in the first picture, you can see that there is just where the pointer is. Now to your right, to your slightly to the left, sir. To the left. Okay, anyway. Okay, sir. So the first picture shows a patient with acute appendicitis with a lot of stranding around the appendix. And the appendix, this is the long tubular structure, which actually is seen between the rectum and the uterus, and it is basically in the pouch of Douglas. Usually, this type of appendicitis is called as pelvic appendicitis, and the typical presentation would be mimicking a pelvic inflammatory disease. Okay, and we should not miss the diagnosis. And again, that is correlating with the ultrasound picture. And the last one is basically an ultrasound picture of a ruptured aortic aneurysm. Okay, next slide, please, sir. So, how do you treat these patients? So, once you diagnose the pathology, once the pathology is identified, you have to treat it accordingly. Any acute pathologies, first thing, usually these are associated with these patients either having associated vomiting or loose motions or lack of appetite. And first thing we should do is admit them and volume replete them. So basically, to admit them and start them on IV fluids. Second most important thing would be to give them pain relief. Pain relief is the utmost. People might think if we give them pain relief, our diagnostic accuracy or diagnostic might miss, but it is seldom the case. First, if we give them adequate pain relief, usually when the worst pain is gone, we'll be able to localize and identify the cause more easily. For example, if the patient presents with diffuse pain, and if you give them proper pain relief, it might localize to either the right iliac fossa, and you make a diagnosis of acute appendicitis. Or if the pain is not relieved, we should think in terms, and as I said, we think in terms of an intestinal ischemia. Okay. On time, what is the time now, sir? 9:09. Okay. So maybe another 15-20 minutes. I think probably once the abdominal pain thing is over, we'll stop for the dinner. Yes, sir. Then accordingly, say for example, you are thinking in terms of appendicitis, you start appendicitis antibiotics early, and appropriate antibiotics should be given. If you are suspecting a torted ovarian cyst, antibiotics might not be needed. However, an early surgery might be beneficial. So other causes, say for example, a perforation is identified, you have to treat it accordingly. If you're suspecting a aortic aneurysm, again you have to involve a vascular surgeon and start the treatment appropriately. Next slide, please, sir. So, we'll just go through. I think I've already shown this slide before. So do not restrict the, what are the, this slide shows the pitfalls and the myths of abdominal pain. So in a patient with abdominal pain, do not restrict the diagnosis solely by the location of pain. So if the patient, in a patient with epigastric pain, it need not be just the stomach or the pancreas or the gallbladder. It can be related to the heart, it can be related to lower lobe pneumonia. So never think about just, it is a guideline to think about the area, but we should never be solely restricting the area and its cause. So in patients with with appendicitis, always think that it could be a potential cause and rule out using appropriate investigations. So white cell count, again, in a patient with acute appendicitis, even though we give a lot of value to through the white cell count, even in acute appendicitis, you can still have a normal white cell count. And if a CT is more specific in diagnosis when compared to the white cell count. However, for the treatment, you might be able to manage the patient conservatively if a white cell count is normal and if the patient is clinically not deteriorating or not septic. So, if say, for example, in a young boy who is actually going for an examination, the white cell count is normal, and if the patient has got pain which is getting better with IV antibiotics, you can still manage the patient with acute appendicitis with medical management, and then do an internal appendicectomy later. So the white cell count is an indicator as to how to manage the patient, but it is not mandatory for the diagnosis. Other thing is that any woman with a childbearing age, you have to always think in terms of an ectopic pregnancy as a potential cause, and always do a pregnancy test in any woman of a childbearing age group before proceeding with treatment of any sort. And in any patient with an epigastric pain, always do an ECG prior to, even if you are thinking that it is an acute pancreatitis or with gastritis, never send the patient home without an ECG. Okay, and in a patient with severe abdominal pain, which is with lack of abdominal signs, always rule out intestinal ischemia. Okay, next slide, please, sir. Shall we go for this thing today, or shall we keep it for another day, sir? We'll just go through the doubts, and then already 9:15, sir.